Hello everyone, welcome to a new episode of our Nottingham podcast case series. Today we will talk about intraoperative anesthetic complications. I am Mr. Gith Kasous, clinical fellow in thoracic surgery in Nottingham University Hospital, and today I'm happy to welcome our consultant anesthetist, Dr. Munib Malik. He's one of the expertise in thoracic anesthesia, and I'm very delighted and happy to have you today in our podcast.
Thank you very much. Glad to be here.
Thank you. Initially, I want to have disclosure that this podcast is intended only for educational purposes. There is no real patient identifiable information is included, and if we are using any images, they are publicly available or sourced from open access platforms. So, Dr. Munib, today we will discuss the most common cases or issues happening during surgery and thoracic surgery from your side as an anesthetist. And this topic is very important for us as surgeons because maybe we are not very familiar like what's happening from your side.
Yeah.
And this topic is common in exams, actually, in FRCS and ST4 interviews. And I believe that every surgeon should know the most common issues in thoracic anesthesia, and we should have very good communication with anesthetists as well during the surgery and before the surgery and after. So we'll go today through the most common scenarios. We'll start with this case. You have a patient, 65 years old, a female patient. She's planned for left upper lobectomy for a central tumor. She has a history of previous MI, and she's morbidly obese. From your side, as an anesthetist, what are your concerns for this patient?
Well, the first thing to know really about someone like this is what the surgical plan is, so that you can then modify your discussions accordingly, because you need to know what type of surgery is going to be, VATS or thoracotomy. Is it going to be lobectomy, sleeve, or pneumonectomy for a central tumour? Because that will modify the risks that you need to discuss with the patient and your plans of how you might manage her. Obviously, in terms of someone who's both had previous MI and is morbidly obese as well, there are issues for the patient regardless of which type of surgery they're having. So we would be assessing those as well in terms of cardiorespiratory function and reserve, how frequently, if any, she's getting ischemic symptoms, and whether she's limited in. If she has functional limitations that and how significant they are, you would potentially need to assess her cardiac function, whether you need to do stress testing or echo testing, depending on what symptoms she describes. The obesity has some implications in terms of how you would manage the airway, how likely they are to desaturate and so on whilst you're doing that, and also in terms of how you're going to position safely during surgery as well. So both of those factors will have additional things you'll need to assess pre-operatively and discuss with the patient.
Yes, and moving forward, that of course, in thoracic surgery, we need usually lung isolation. So, what are the types of single lung ventilation? What options do we have?
Essentially, for any type of lung isolation, there's only a limited number of options. I.e., you can have a double-lumen tube insertion, or a blocker inserted into the bronchus, or you can use a single lumen endobronchial intubation as essentially the main forms of lung isolation and one lung ventilation. The first choice in general for patients having lung surgery especially is a double lumen tube rather than one of the other devices, mainly because they've got significant advantages in terms of both the surgical conditions as well as the practical aspects of managing the patient intraoperatively, because you have much better access to the airways to deal with hypoxia, to deal with suctioning, deal with bleeding, which are much more limited with any other device. There are downsides, which unfortunately, due to the bulk and the size of the tube and rigidity of the tube, you can have more issues with insertion and with trauma from the device, but overall there's significant advantages.
And what, let's say, a part of having surgery, what there are indication for double-lumen tube, when absolute indication in emergencies, for example?
Yeah, there's various situations where you might want either lung isolation or single lung ventilation, or both, and that's where you would consider these devices. And the situations such as one-sided hemorrhage or infection or air leak, where you might need to isolate and avoid contamination or loss of ventilation as a consequence.
Like a massive hemoptysis or bronchoprofistula, for example.
Many of these kind of situations where the other lung that is not being affected could become affected by that. And sometimes you want differential ventilation when you've got a single-sided lung injury. There are situations such as bronchopulmonary lavage where you need to isolate to be able to undertake that procedure and wash out the lungs as well, which is a rare thing, but sometimes it could be indications.
And what are the difference between right and left double-lumen tube, when to select right or left double-lumen tube?
Generally, most of the time we would use a left-sided tube as a default, regardless of where the surgery is, because insertion and successful positioning of the tube is much better with a left-sided tube, and there's much less likely to run into problems intraoperatively. With a right-sided tube, you have to have accommodation of the right upper lobe position, and that to allow for that, the tube has a Murphy's eye on the side of the bronchial limb, and it has a different shaped cuff to allow it to sit and hopefully accommodate the right upper lobe. But the right upper lobe position can be variable, and sometimes it can be very difficult to get that optimally placed. So you run more risk of hypoxia due to issues with the right upper lobe. But the only times when the left-sided tube is not suitable is when surgery might involve the left main bronchus, so left pneumonectomy or a sleeve lobectomy would necessitate putting a right-sided tube in to prevent that, or if there's been previous surgery in the left side and you need to avoid that.
So a part of the double-lumen tube, what are the other options for lung isolation?
So the other devices, you have an endobronchial blocker. Is probably the next most common device you would use. You can place that through a single lumen tracheal tube, and then you place a ballooned catheter essentially into the bronchus that you want to stop ventilating. And there's certain situations where that is maybe the only choice, and sometimes where it may be the preferred choice. But essentially, if you have a situation where double-lumen tube insertion is going to be problematic, whether it's a difficult airway or a narrow trachea or a very small patient, sometimes these situations you might want to use a single-lumen tube and do a different mechanism of insertion and then use a blocker through that. But the limitation there is that you don't have access to the blocked side to be able to clear any secretions or blood, to be able to insufflate oxygen. So they can become more limiting during the surgery than to be able to handle any issues that happen. Sometimes they can be fiddly to place and to keep in place, but generally speaking, they're not too difficult to insert.
And how do you decide what size of the tube to use based on what?
Generally speaking, it's down to gender and size of patient. In terms of the sizing of double-lumen tubes. So a typical male patient would generally use a 39 French tube. A typical female patient would use a 37. And then if they're particularly tall or particularly short, we might then use one either side of that. And as a rule of thumb, probably when someone is around about 180 centimeters, you probably be thinking about stepping up a size. At the top end, and at the bottom end, if they're below 160, certainly getting down to the low 150s, you'd be going down to maybe a 35 tube. But that's, as a rule of thumb, that generally works. Obviously, you can look really logically to see what you think in terms of size of trachea as well, if there's any pathology in the airways.
Okay, let's say that we had a difficult patient and we couldn't insert double-lumen tube or even endobronchial blocker. So what options do we have?
The options become quite limited in that situation. Obviously, you need to consider whether you really need the lung isolation as an absolute necessity, or whether it's just to try and get the optimal situation, but you could actually cope without. But assuming you do need lung isolation, the only realistic option then becomes to put a single lumen tube endobronchially. And there used to be availability of specifically designed endobronchial tubes, which were a 6.5 size, but as far as I know, they're no longer available. So you'd have to use a conventional tube. So again, at similar size, either a 6 or a 6.5. You could use smaller if needs be, depending on any other pathology that might necessitate that.
So like we will put like single lumen tube in the lung that we need to ventilate, and the other lung will be like collapsed.
So that would have a cuff on it within the bronchus that you're ventilating, and then the other side would have no access to ventilation during that process. Again, you don't have access to that bronchus.
Is it the same what is the intermittent ventilation?
No, intermittent ventilation then would become a case of if you can't isolate the lung, you can intermittently ventilate so that you have periods of apnea where the lung operative side can be more stable for the surgery, and then to reinstate ventilation to restore oxygenation intermittently. You can use high frequency jet ventilation as another alternative, where you retract the lung and put a high frequency jet ventilator on to 2 lungs, and the lung will not re-expand. It will just stay where the retractor is, because the pressures in the airways are much, much lower. But then you will not have isolation in that situation. So contamination is still a risk, but you will be able to have effectively a collapsed lung to operate on.
Okay. One of the maybe complex scenarios when we have patient with tracheostomy. So in these patients, what options of lung isolation, and can we use double-lumen tube for this patient?
So just to cover the double-lumen tube part of it, generally no. There is a double-lumen tracheostomy tube available. Locally, we don't stock that anymore because they were used so rarely that it was pointless. To use a conventional double-lumen tube through a tracheostomy site would be potentially traumatic, and I wouldn't advise it. Although you could try and do it, but it would be more trouble than it's worth, I would say. So if they either have a tracheostomy in place or they have a stoma from previous laryngectomy, you can put a tracheostomy in place. Then you would then leave that in place and use an endobronchial blocker through that. It would need to be a size 8 at least to be able to facilitate getting the blocker in and a fibre optic scope at the same time. But you'd need either an 8 or a 9 tracheostomy tube, and then you could put the blocker in that situation. If the surgery was on the left side, that would be the preferred option. If surgery is on the right-hand side, putting a blocker in there sometimes can be less effective in terms of making sure the lung collapses properly. And so putting in a size 6 armoured tube into the left main bronchus through the tracheostomy site might be a preferable option. You can use a reinforced adjustable flange tracheostomy, which should be long enough to do that, or a conventional oral tube through the tracheostomy site into the left main bronchus to ventilate the left lung and leave the right lung to collapse.
Okay. I think we covered most common questions about the type of lung isolation. We'll move now to a different scenario. That let's say that during the surgery, you notice that patient dropping his blood pressure. What are your differential diagnoses and how we will approach them?
Okay, it's quite a common scenario to have a degree of hypotension during any anaesthesia, but obviously there's various things that could be more acutely problematic that have caused it. You would be alert for anything sinister, but the common things such as the anaesthetic medications, a degree of hypovolemia would be kind of initial thoughts. But if there's any suggestion of either bleeding ongoing at the surgical site, either occult or visible, or whether there's any other signs of physiological deterioration in the patient, that might suggest a cardiac problem, might suggest a pneumothorax on the ventilated side, or potentially even anaphylaxis, depending on what stage of the process it is. These are the kind of other things that could cause hypotension as an early sign of.
Let's say that we have a case of suspected anaphylaxis. What you will do as an anesthetist? How you can manage this?
One of the main things with anaphylaxis is to suspect it in the first place, because there's so many things that can be going on, especially under anaesthesia, that sometimes it's not high up on the list because you haven't given something that would have potentially triggered it immediately before it happening. And if it's a delayed process, sometimes recognizing that is potentially a risk and then initiating treatment can be one of the biggest problems. But assuming you suspect it, whether there's airway pressure changes or there's rashes going alongside the hypotension that make you think it more likely, or whether you have just given a drug that you think this could be the case. Once you've suspected it, you need to initiate the treatment of giving adrenaline, essentially, is the mainstay of treatment. In theatre, that may well be by IV route. Obviously, outside theatre, that's not necessarily the first line treatment, but in theatre, either a combination or IV boluses plus or minus infusion, depending on how persistent the hypotension may be. You may need to do other treatments alongside that, but that would be the first thing and the main thing to get in place.
And do you give like any steroids as well?
The additional treatments alongside that would potentially be useful. So you can use other bronchodilators, you can give steroid. Less so now, people would have used antihistamines as well. So fluid therapy and positioning of the patient to help venous return are other things that may be relevant. 100% oxygen, depending on how the ventilation and oxygenation is going, are all additional things that you need to do. But unless you start the adrenaline therapy, then you're not going to prevent and stop further progress of the anaphylaxis. So that needs to be the main thing to start early. And then there'll be the secondary treatments and also blood tests to be taken to make sure you can confirm later if it was anaphylaxis or not.
Okay, and regarding arrhythmias, what are the most common arrhythmias that you see during the surgery and thoracic surgery, and how you are dealing with them?
We quite commonly see short bursts of rhythm changes due to any kind of intraoperative manipulation around the heart. And because they're short bursts, short-lived, self-terminating, they're not really things we need to do anything with. Occasionally we can see an arrhythmia which is persistent and problematic, and we need to treat. And we can see a variety of things. Fibrillation is quite common in any kind of lung surgery, but usually happens a bit later, but it can happen in theatre. If it's at a fast rate, that's something that may be compromising the patient that we need to rate control with beta blockers to deal with. Sometimes you might need to consider second-line treatment with amiodarone, but you want central access for that. Usually, initial rate control would probably be the mainstay.
Okay, good. So now moving to different scenario, and which is like, I think we are meeting this scenario in many cases. Like it is desaturation during the surgery, or sometimes the surgeon keep telling anesthetist that lung is still up, his lung is inflated. So, and we are very annoying, I know, for that. So how you are approaching this scenario, desaturation or poor lung deflation?
It's never annoying. It's always good. We work together very closely, so it's we need to know from both sides how things are working. In terms of the lung deflation, there's a limited number of things we can do. Obviously, we need to make sure the lung isolation device has been placed correctly, and that might require rescoping with a flexible scope to check the positioning of things. If the positioning is optimal already, then any further issues with collapse is generally down to either the airway resistance or secretions within the airway. So you may be able to do something about secretions, especially with suctioning. You can use either a blind suctioning to clear thicker secretions, and then you can use the fiber optic scope to go sequentially through the different airways to try and clear anything more distally. And beyond that, unfortunately, there's not much else you can do to empty the lung faster. And then it would be down to retraction and working around whatever residual volume is trapped within the lungs. Desaturation is quite a common problem, as you'd probably expect with switching from 2-lung ventilation to 1-lung ventilation. Desaturation isn't unusual. Thankfully, most often it's not to any significant extent, and it will start to improve during the course of the procedure as the physiological mechanisms resolve the blood flow situations. But there are certain things that you might need to do if the desaturation is more significant or not resolving. Again, we need to make sure the tube that we're using is actually optimally placed and the ventilation is getting through to the lung that we expect it to. Assuming that we're delivering oxygen appropriately, you can increase it. I tend to find going above 60% isn't really worth it, but you can increase the inspired oxygen. But once you're happy that the oxygen is being delivered and the ventilation is appropriate, you then need to do other manoeuvres to try and improve the oxygenation further, which is usually down to shunt, where blood is going to the non-ventilated lung still, and therefore desaturating the patient. You may have further collapse in the ventilated lung, especially in a big patient or in a patient who's got limited lung function to start with. So recruitment manoeuvres to help expand that lung and maintenance of PEEP on that lung can help, although you don't want to go too high, and by which I mean, significant levels, 10 plus of PEEP, where you might start to divert blood flow to the operative side. Before you then start looking at potentially putting CPAP on the operative side, which may interfere with surgical access as the lung starts to retain a bit of volume. So you do that in discussion with the surgeon. If this saturation was still problematic, you might start to either apply CPAP or intermittently ventilate to a small extent on the operative side.
Operative side, okay. So what ventilation mode do you use during the surgery?
Ventilation modes?
Yeah.
Personally, I use pressure control ventilation when I'm doing thoracic surgery, mainly because the switch between 2-lung and 1-lung ventilation doesn't produce any significant problems with volume changes and pressure changes, and it's more instinctive in terms of whether an appropriate volume reduction has occurred going to 1-lung ventilation due to the reduced compliance of having just 1 lung in the system. And it's more obvious then what changes have occurred. And then during the case, if you get further volume changes, it's more apparent. So if you have problems where the lung is collapsing to a certain extent, you'll see the volume changes rather than on a volume control mechanism where you'll have pressure rising and it's not as immediately obvious.
Okay. And of course, like if patient continue to desaturate, and I think at the end you need to ventilate both lungs, and here it comes to we need to of course be on continuous discussion between surgeon and anesthetist.
Absolutely.
What are the best for the patient. And I in one of our podcasts I discussed that with our consultant, that if we we failed to deflate the lung, we need to convert to open and operate on ventilated lung. This is the last resource.
Absolutely, yeah. There's very few situations where it gets to that level, thankfully. But sometimes a patient may not tolerate one lung ventilation to be able to maintain that throughout the whole procedure. As I say, intermittently ventilating may give periods of a few minutes where the saturation stays adequate, and then you have to stop surgery and then you reventilate for another 30 seconds to restore saturation, then have another few minutes of operating. That may get you through the situation, but potentially, if that is not either achievable surgically to do it in that way, or if it's just not achieving the saturation you require, you may need to go back to 2-lung ventilation. Obviously, with an endoscopic approach, that gives you very, very little space in the chest to do anything. So chances are you're going to need to be doing an open procedure and using retractors to get the space to do the surgery. And obviously, that is a consideration as to whether the surgery is suitable then for the patient. Are they going to be able to tolerate it if they're that bad? Depends on what the procedure is, but you may need to consider whether you need to modify what procedure you're doing,
of course,
or consider abandoning completely if the patient is that unable to oxygenate.
Okay. Moving to our last scenario, or like last part of discussion about post-operative pain management. What options do we have, and what do you prefer? What's the advantage and disadvantage of each of them?
The pain management side of things has evolved over the years as we moved surgically from open surgery to endoscopic surgery, and then try to become more minimally invasive, I guess, in all aspects of what we do to get the best outcomes for the patient. And I would say initially with open surgery, certainly locally, thoracotomy would equal an epidural as the main approach to management, and that probably is still what we would say locally, although in other locations paravertebral was the first choice, and that has some advantages in terms of the patient physiology, and so both are perfectly reasonable for managing thoracotomy, depending on the patient and the risk factors involved and the local institution experience of using those approaches.
What are the advantages of epidural over the paravertebral, or and the opposite?
Locally, we found that epidurals give us more consistent results in terms of good quality analgesia. As I say, other places who use paravertebrals routinely have very good abilities to manage them, and I think it's down to both the familiarity of putting those devices in place and also managing them post-operatively, that will get the best results out of the thing that you used routinely. Both have been shown to be very effective at managing the pain to a similar level. Often you do need a little bit of systemic analgesia alongside a paravertebral, which you don't need, generally speaking, with a well-placed epidural, but they can both provide very good analgesia. There are some downsides with epidural in terms of where it's positioned and the risks associated with that, and also with the physiological changes, i.e. when you put an epidural into the epidural space, you could risk hematoma or infection in that space, which is potentially a significant complication for the patient, as well as neurological injury. And also the sympathetic blockade from that can produce hypotension, which managing that post-op may produce additional risks for the patient. Those are generally avoided by paravertebral, which is also suitable in patients with a degree of anticoagulation on board. So there's certain things that might sway the choice between the two, but I think the main thing that tends to determine the first choice is institutional experience of which device to use. And both would be used in open surgery, essentially. For VAT surgery or robotic surgery, it's very different because the level of pain, thankfully, is much less and less prolonged as well. They still need significant analgesia, but we can manage that generally with a good systemic multimodal approach and initial regional analgesia with intercostal blockade. Some places use chest wall blocks, but intercostal blockade is directly inserted by surgical vision is a very effective initial regional anaesthesia, and then supported by systemic analgesia afterwards.
Good. We are reaching now the end of our podcast. Thank you so much for your time and joining us. It was very useful discussion, and myself, I learned a lot today, especially in how to manage the desaturation, the lung isolation. It was very useful for me to understand the options, and it's important to communicate with the anesthetist to know, because like we are one team and we
Absolutely,
need, yes. So thank you so much for your time and for this discussion.
I think it's always good to try and bridge those working practices between the two so we can all work together and make sure we get the best results.
Of course. Thank you so much for your time, and have a good day.
Thank you.